Hey there, and welcome to the Knee Gurus, your guide to understanding knee injuries and recovery. I'm Bevan Collis, physiotherapist and founder of Asia Physio. With our clinics in Japan and Singapore, we help people get back to doing what they love. Each episode, we dive into real stories and expert conversations about life after a knee injury, from surgeons and physios to patients who've been through it all. So whether you're fresh off an injury or just curious about your options, you're in the right place. Let's get started. Okay, welcome back to the Knee Gurus podcast. I'm your host, Bevan Collis, and today we are diving back into our discussion on skiing ACLs. So this is part two of a two-part episode. So if you haven't listened to the first episode, I'd highly recommend you go back and listen to part one first. And we've got our two incredible guests again, Dr. Tom Cross, who is a well-known sports medicine doctor from Sydney, and his innovative work around the cross bracing protocol and ACL rehabilitation has really been revolutionary for ACL management across the world. And also alongside Tom is Ryan Kerr, who is a physiotherapist who's spent his career predominantly in snow sports injuries and high performance ski races management and treatment. And he's been managing real world ACL injuries in mountainside environments. So great to have you both back again, guys.
Thanks a lot, Ben.
Thanks, Ben.
Ryan, so we were just wanted to dive in a little bit about to talk about ACL prevention. So if some of our listeners are skiers about to go on a ski holiday or thinking about how they can avoid ending up with an ACL tear, what sort of advice would you give them around ski lessons, ski selection, din settings, binding choice, and those sort of all those variables that can, unfortunately, often be contributing factors to somebody tearing their ACL?
Yeah, for sure. It's probably one of the most common questions I get asked, and I'm sure it's the same with you, Bevan. I think the way that I like to answer this is I like to split it into the ski specific things and the general things. And injuries are always multifactorial, so we can never truly prevent an injury, but we can address or mitigate some of the things that contribute to injuries. And I think some of the general things can't be ignored for all sports, and that's like strength and conditioning, being as strong as you can for your sport, not being sleep deprived, getting a good night's sleep, and being in a good mental state. So there's a lot of evidence for that sort of stuff for all sports. But the more interesting stuff, I guess, is for skiing. And I think we can start talking about equipment first. And most skiers will know about the DIN settings, which is how tight your bindings are. I think foremost, it's important to have the DIN setting right for you. And that doesn't necessarily mean having the DIN turned down really low either, because I've seen a number of ACL injuries where a ski has pre-released, which means that it's come off when you didn't want it to, and then that's been what's caused a crash. So having a DIN setting that's correct for what you're doing on your skiing and your height and weight and all that sort of thing is super important. And essentially the DIN is how much force is required for the ski to come off and break off the binding. And when it's too tight, then that a force that might not turn the ski off or might not break the ski off or clip it out of the binding will then get transmitted up your leg and into the knee. So when you're doing that, there are a few charts and stuff out there, but you need to get your DINs checked by a certified binding technician. So that'll be someone at the ski shop or at the rental shop, and that's your first port of call to making sure that the DIN is set correctly for your rental ski or for your own skis. And that needs to be adjusted and changed as you change boots. So if you go and get a new pair of boots, or you just bought a new pair of boots or swapped your boots out at the rental shop, it's important to go and get that recalibrated or reset on your binding so that it's lined up there correctly. And then I think as well is making sure your bindings themselves are in a good working order, because that setting at what point the ski is supposed to release out of the binding is standardized. And if your bindings are rusty or they don't have any, like there's some grease that is in some of the moving parts of the binding, if that's not right, then the ski may or may not release at what it's supposed to release at. So sometimes you see people with those lovely old skis that particularly in love with from many, many years ago, sometimes it can be unsafe to stretch the life of your equipment out a little bit beyond what it's supposed to be. So make sure if you've got old skis that you love to use as well, get them checked by a binding tech and making sure that everything's still working as it should be. I think that's a really important one. The other one's correct fitting boots. People that often ski in boots that are way too big for them, you'll create a torque inside your foot or movement inside your foot before it actually starts to connect with your foot and twist your leg. So the ski can start to move and accelerate on like a rotational plane before your muscles and your brain and your body can feel it's moving and then stop or make a movement to slow that down. So people, especially those with wider feet, might get boots that are much too long for them to accommodate the width of their foot. And that can or is hypothesized to contribute to injuries by slowing down your reaction time and your ability to feel the snow. So ensuring you have a correct fitting boot, and that often means if you're skiing regularly and it's within your budget to actually purchase a custom fitting boot which fits your foot so that you can feel what's going on in the snow and what's going on in the ski, and then make the adjustments and movements with your body to compensate or to do what you want to do to recover from losing your balance or something like that. So that's another part to do with your equipment. And then yeah, I guess that the last part of that is to think about your ski technique. And I think especially in the beginner and intermediate stages, getting a few ski lessons to learn the right and wrong thing to do when you're skiing will go a long way to help reducing the risk of injury. Skiing is quite an unnatural sport. If we think about comparing it to like, I don't know, footy or soccer or another field-based sport that's based on running, jumping, throwing, catching, they're all very basic human athletic movements that we do. But when we're strapping ourselves onto some skis and on a slope, all of a sudden we've got to tell our brain to be in a position we don't want to be, which is leaning forward relative to a slope as opposed to being perpendicular to gravity and planet Earth. And often what will happen is people will tend to lean back or lean in different directions to what their brain thinks they are relative to where they should be. So that can be like leaning back up the hill or leaning back on the skis because that's what feels natural and normal relative to gravity and planet Earth, when really we need to be in a different position. And that can put us in a compromising position because of the way the equipment's set up. If I continue to use that example of leaning back, you've got the back of a hard plastic ski boot, if you can imagine that. And if you lean backwards on that, that's actually sort of shifting the tibia forward with your weight. And so you're already putting a little bit of strain on the ACL before you've even started making any turns or started moving. So ensuring you get some good lessons in the back, especially in the early stage, to learn how to stand on your skis can be super important. And then as you progress on, skiing with what we call in the instructing world as separation, which is separating the upper and lower body to skis. And that means that we're predominantly turning the skis with our hip joint so that our pelvis and upper body stays quite stable as we rotate our legs underneath. That means that we rotate our entire leg in the direction of travel, and it allows our knee and ankle and hip to flex up in a straight line with the ski when we're absorbing force and absorbing undulations in terrain. So as you start to ski a little bit faster, if you can develop good separation, that'll put the knee in a much more comfortable position as you deal with absorbing force and different things that come about. So, I mean, they're just a couple of examples of how technique can make it easier, but I think it's super important for people to consider that when they do go on their ski holiday, that if you're worried about reducing the risk of injury by making yourself more efficient and better at the sport, it could go a long way. Does that sort of answer your question,
Yeah,
Bevan?
terrific. And also, I think that you touched on it just about the general health of being strong and being fit, having strong quads, doing some conditioning before you go on your trip. And then also on the day, be aware of your own sort of mental and physical state throughout the day. You do certainly, it's the old cliche, it was always the last run of the day. I was feeling a little bit tired. Your muscles get tired and your technique drops, but also you get a bit mentally fatigued as well. And a lot of people are having late night dinners and they're on holidays and not always fitting to high performance recovery schedules. So after 3 or 4 days skiing, they're starting to have that build up mental and physical fatigue that allows you that sort of contributes to a little bit more sloppy skiing. And as you say, getting a little bit more backseat, which all increases the risk of ACLs. And I think the other thing that I did want to
touch on that maybe can help people is a lot of the time people aren't choosing their own DIN settings. That's the ski tech in the shops, and we have a lot of discussion with those guys because a lot of people who tear their ACL can kind of you do end up talking about what DIN setting they were on. And I think it's important for people to be really honest on their level of skiing, because if they're overestimating, or as you say, underestimating their level of skiing when they're choosing a DIN setting, they can end up with a ski that is too tight and not releasing early enough for, because there is a formula, as you say, they should be weighed, they should factor that in with their level of expertise to choose that DIN setting, which is really crucial.
Yeah, I guess just on that as well, it's important. I think it's important for people to be aware that DIN settings weren't invented to protect ACLs. They were designed to reduce lower limb fractures. So once they had the invention of modern bindings, we saw the tib fib fractures decline, but ACL injury rates increase. So,
Yep.
and that's because often the way that a skiing ACL injury happens with internal rotation, where the force can be applied posterior to the leg from the back part of the ski, and there's no release part for that part of the ski, and you couldn't have a release part of that part of the ski because then you would come out of the binding all of the time when you didn't want to. So I guess, yeah, just because you have the DIN setting perfect doesn't mean that you're ACL proof, but when you get it wrong, it can definitely increase the risk of doing an ACL injury, if that makes sense.
Yeah, terrific. I hope that helps our listeners avoid ending up in one of our clinics on their ski holiday. So maybe now we can dive in and talk a little bit about what to do if you have unfortunately torn your ACL on a ski holiday, which is always very disappointing for people who've been looking forward to a ski holiday all year and end up unfortunately injured. And I know in our clinics in Japan, we've certainly changed the way that we manage those acute ACL over the years. Probably if we go back before the days that we understood about the healing potential of ACLs, we didn't used to restrict our range of motion at all. We'd allow people to straighten and bend their knee as much as they liked. We put a simple brace on to provide a little prevention and support. But these days, we're now restricting people who we think have got an ACL between 30 and 90. And we're also doing a lot less Lockman's test, which for non-medical people is kind of a jerk on the tibia to see what the end feel, or you sort of taking the ACL to the end of its length, and it's actually quite a reliable test for diagnosing ACL. But there is some discussion that now we understand there is a little bit of a risk involved that you could potentially jerk on an ACL that's recently torn. There is some belief that maybe we might even increase the tear slightly by that sort of tugging tear. We never really do pivot shifts tests because, which is another test for ACLs that tends to be effective for surgeons when patients are under general anesthetic. But when people are awake, and particularly in the first few days after injury, they very rarely allow you to do it because you're sort of recreating the mechanism of injury, and patients just hate it, and you tend to just lose the trust of the patient if you're doing a pivot shift on a really acutely injured knee. So for us, it's a very gentle, simple Lockman's, and we're even moving towards not doing a Lockman's if someone's got a history that's so clearly pointing to an ACL. We're sort of managing it as if it's an ACL without doing the Lockman's. A knee brace to provide the stability, 30 to 90 degrees, and we're talking a lot about DVT prevention and preparing them for their flight home. How about you, Ryan? Have you guys changed the way that you've been managing ACLs since the cross bracing protocol and our new understanding of ACL healing?
Yeah, absolutely. Mainly influenced heavily by Tom over the last, especially since the last 4 or 5 years. We do the same thing now. If get our patients into a blocking them at 30 degrees extension. So for our non-physio medically minded listeners at home, that means if you've got a knee straight, we'd call that 0 degrees. And then if you flex it just a little bit, we'd call that 30 degrees. So we put you in a brace that blocks you straightening it beyond that point of like a little bit of flexion at the knee, and then advising people, yeah, just like you said about the DVT risk, which seems to be the biggest risk, or is the biggest risk after an acutely injured knee, and then telling them to just take it easy and be pretty comfortable in the first couple of days, maybe resting at home on the couch with a pillow under the knee for comfort. But yeah, pretty much exactly what you said. Although I'd like to pick your guys' brains, and Tom, you mentioned it in the first episode, as well as to you guys moving away from the Lockman's test. After speaking to Tom a few years ago, I've started to try to be really gentle with how I do it, and I've really thought about how I do that movement. That's again what Bevan said, the test we do to see if the ACL has been injured or not. So yeah, do you guys have any, just for my learning as much as the listeners, about how and why you've moved away from that and what you're doing instead?
Bevan, do you want me to answer that?
Yeah. I'm pretty much said what we do. We still do the Lockmans. I don't think we've totally banned it in our clinic. Like we have the pivot shift. We don't really find much use in the anterior draw either. But yeah, it was a little bit disappointing to me. I was very proud of my Lockman's technique always, and having done hundreds and hundreds of them over the years, I was kind of. I was quite proud of my ability to diagnose the Lockmans, and people would come back and say, "Oh, yeah, it was an ACL," and I'd say, "Yeah, I knew it was an ACL. I did the Lockmans. It's fine." But yeah, certainly we moved away from it. But I'll be interested to hear, and a lot of that on Tom's advice. So I'll be interested to hear how you are managing your acute ACLs in the first couple of weeks now, Tom.
Well, I think the ski environment's a very different environment to being pitch side at a soccer game in Sydney or wherever you are in the world.
Yeah, isolated.
But yeah, so you're often in an isolated mountain area. But I think wherever you are, the patient deserves to know what their possible injury is. So I think I've been saying, knowing what I know now with this research, is I think it's incumbent that someone diagnoses the patient, and whether it's a fantastic physio that has a real interest in knee ACL and can do a very effective Lockman to diagnose, or it's a doctor or a surgeon, orthopedic knee surgeon, but someone has to diagnose it on day 0 or day 1. But you just say to the team around the patient, let's just get one person to do a Lockman. We don't need to do multiple Lockmans. We certainly don't need to do a pivot shift. That pivot shift, I think, is when the patient has decided that they want surgery, and they're going down that pathway, and the expert surgeon's trying to work out what's the right approach to that knee and how much instability the knee has. So they'll do a Lockman and a pivot shift, and then decide how lax they are and whether they need to add what type of graft to use, and whether to do a lateral reinforcement procedure because the patient's so unstable. But say the patient comes into the ski resort in Verbier or in Niseiku, Rizutsu, wherever the Asia Physio is in Japan, or they're in Elevate Physio in Jindabyne, or they're in Mount Buller, etc., or they're over in Coronet Peak in New Zealand. Wherever they are in the world, there's expert physios and doctors in those clinics that can make the diagnosis, and you check the medial ligament as well. 20% of the ACLs I've managed have a grade 3 MCL coexisting with the ACL. So there's these skiing ACLs, 20% of them have a high grade MCL. So I think you should diagnose that as well. And you only need to do these tests very gently. Use a very gentle test of the MCL, very gentle Lockman, and then say, okay, based on the history, my examination, this is what you've got. And knowing what we know with this research, we would advise putting the knee into flexion and putting them non-weight bearing on crutches to protect the ACL. So it's not, you don't turn a certain tear type that might be healable into a more serious tear type or more profoundly injured ACL. If they fall over, walking around in Niseiku on the slippery ice, and then have another injury and then increase their gap distance. So we would say put a brace on. We've started to use 40 to 90 now, because if you use your goniometer, 40 degrees flexion of the brace equals 30 degrees flexion of the knee in the brace. And 30 to 90, 30 really gives you a 20 of the knee flexion inside the brace. So
we're the same, Tom. We do the same.
Yeah. So the flexion gives you a bit of approximation of your ACL. They can certainly touch weight there so they don't fall over, but you try to give them crutches, say, look after this knee. And we need to get you home safely if you're in a remote area. So we call this the traveling ACL. There's another interesting facet to the CBP research is we spoke to hematologists and vascular physicians, vascular surgeons. My father and I, back in 2019, when we decided to embark on this research, we said, well, how do we protect people from getting a DVT and a PE and, God forbid, dying? And they said, well, you need to do a Doppler on every patient you're considering doing CBP on. So we did. So we did Doppler ultrasound on the first 400 people who adopted CBP. And what we found was the only people who got DVTs, whether they were symptomatic or occult, were the travelling ACLs. They'd been injured down at Perisher or Thredbo and then driven back to Sydney, or they were injured at Mount Buller or Hotham and then driven back to Melbourne, or they got on a plane and come back from New Zealand, Japan, North America, Europe, and landed back in Australia. They're the travelling ACLs. Everyone who stayed in Melbourne, Gold Coast, Sydney, Christchurch, and ruptured and stayed in their city, none of them had a DVT. So that's another interesting piece. We haven't published that. So if you are that skiing ACL that gets injured in Verbier or in Niseko, go to the excellent clinic, get a diagnosis, get a knee brace on, crutches, get told how to mitigate the risk of DVT and how to get home safely. And this is a whole new topic of how to clinically manage the ACL. Some of these patients, they get injured on day one and they're with their family, friends, and they might have it another two weeks in Japan. And they don't want to come home early. So there's this conundrum of, look, I really need to diagnose what I've got, and I need to get triage into how badly hurts my ACL. Do I have other injuries in the knee? And then balance that versus traveling with their loved ones and friends. So, but us as physios and doctors, we need to look after the patient so they don't get a blood clot. Because if you get a DVT, a lot of your options are taken off the table, and the DVT trumps an ACL. You need to save that patient not to get a PE and die. I know I'm being dramatic, but it's that serious. So you'd say to the patient in Niseko, let's put some compression garments on. These are your foot and ankle calf pump exercises. We want you to do these exercises. We want you to come into physio for the days, for the rest of your holiday. Try to come in every day and we'll work with you. It's very hard to get anticoagulation medication when you're overseas, because you're an Australian in Verbier or in Japan, and a lot of the doctors won't prescribe it. And in a way, you shouldn't really start the anticoagulant in the first 3 or 4 days, because you'll increase the bleeding or the injuries in the knee, whether it's ACL, MCL, meniscocapsular injuries, and you'll turn a small to moderate hemarthrosis into a more serious hemarthrosis. So in an ideal world, you'd wait 3 or 4 days, get looked after by an expert physio clinic, and then decide, okay, I'm going to travel on day 4 or 5 after my ACL, and I'm going to get home safe. I'm going to try to get an upgrade into premium economy or business if I've got travel insurance. If I can get a prescription for an anticoagulant, fantastic. And we'd recommend one of the oral medications, rivaroxaban, which is Xarelto, or apixaban, which is Eliquis, or you could get an injectable anticoagulant like a Fragment or heparin. Don't use aspirin. Aspirin's not as effective for DVT risk mitigation. Try not to have too much alcohol on the flight. Don't use sleeping tablets. If you've got a brace on, take the brace off and put it in the overhead locker. Don't have the straps really tight. and just do all the foot and ankle calf pumps all the way home. And then when you get home, you have a mandatory Doppler. So you have to do a Doppler on the traveling ACL to make sure they don't have an occult DVT. But you also clinically examine them, do a Homan's test, palpate their calf. I picked up a few occult DVTs that the patient didn't even have symptoms. So yeah, but that paradigm shift, that it is important to diagnose the ACL and tell the patient where they've landed on that spectrum of injury, and then go back to the patient and say, well, this is what rehab alone looks like. This is bracing 30 to 90. This is one of the CBP prescriptions, and this is surgery. And based on who you are as a patient and what your pathology is, you need a surgeon, and we're going to triage you to the best surgeon in our city, or a choice of there's usually multiple excellent surgeons, or you might be a candidate for this treatment. Do you want to try this first? And this is what this looks like. This is the effectiveness of it. This is the safety. This is how challenging it is. These are the complications. What would you like to do? Now, to get all your ducks lined up so that the patient's got all those options on the table, I would argue you really need to be having that conversation or that consultation, hopefully in the first 10 to 14 days. Remember, you can't take their knee to 90 in the first 3 or 4 days. They've got an acutely injured knee, and as soon as you take them to 90, you're beholden to anticoagulate them. So that's another lesson. Don't take someone to 90 who hasn't been classified and who hasn't been given a prescription for an anticoagulant. So that's crazy, because you could hurt someone. Yeah,
crazy to go to 90 before any long trip as well. So I don't think we've never put a patient at 90 in any of our ski clinics.
No, yeah, I know you haven't. So, but some people get quite enamored with this idea of I can heal this ACL, and I'm going to put the patient at 90 before they've had an MRI, before they've seen a doctor. So we really want to get that messaging out to the community that, and once again, we're still gathering scientific papers, but so far, 1,400 patients into the treatment. It's proving effective and safe, what we're talking about today in this podcast, having this sort of algorithm of treatment or approach. If the patient decides to go traveling around Europe for a month after their ACL, and that's totally okay, they lose the option of facilitating their healing. We believe that it'd be like walking around Europe with a ruptured Achilles, or and thinking you might be able to non-surgically treat that ruptured Achilles when you get home to Sydney. There's an urgency to approximate the tissue that's been freshly, unfortunately, injured, and to reduce it and immobilize it to try to promote the healing or the cross-bridging of collagen. So the patient needs to be told that you might have another 7 days in Japan or Switzerland, but you really should be getting home to get triaged, have a really good high quality MRI, get a Doppler done. Let's mitigate the risk of DVT. So that's the messaging. And just finally, if the patient is triaged to surgery, by all means do a Lockman and a pivot shift. And the expert surgeon does that to start plan their surgery, and they often can do it under anaesthetic. And they tell the patient, look, I'm going to examine your knee under anaesthetic and see what sort of instability you have to plan. But you shouldn't do multiple Lockmans. I never do a Lockman when they come in at day 5 because I've got an MRI. Someone else has done a Lockman. Why do I need to do a Lockman? I need to look at the MRI, and that'll give you it's a ruptured ACL. If it's a partially torn ACL and there's some continuity, obviously they're going to have a different Lockman. You'll have a different end feel. So I think in the days where you've got MRIs, there's no need to do a Lockman in the clinic unless you're committed to surgery.
Yeah, no, that's the luxury of being in a city where
I guess you probably do the same, Bevan, but whenever I suspect someone's got an ACL, I always tell the patient, now, until we get an MRI, don't let anyone touch or pull on your knee until you've got the MRI. So I guess for the listeners out there, if your physio or doctor suspects that you've got an ACL injury until you've got your MRI sorted, don't let anyone like yank on your knee or pull on your knee or do any sort of funny movements.
We do
Yeah, we
say that,
don't.
but
We actually don't know whether the multiple allotments make the tear type more severe.
it
An
can be hard.
underspaced into a displaced ACL. We don't know, but we're just trying our best to help the patient. What will hurt the knees if they fall over again and their knee gives way violently a second time?
Mm.
So, you know, patients who have had an ACL at a low velocity and then try to ski down the mountain, their knee gives way again. You never know what they had the first time. You just know what the ACL looks like after their second giving way.
Yeah.
So that's the idea of protecting the knee from further instability events.
And as far as the time window to enter a bracing protocol, whether it's a 40 to 90 or going all the way to being locked at 90, from what I understand, Tom, in the early days, you were sort of excluding outside of 21 days, but it's that window's kind of narrowed a little bit as your greater understanding of involution and how the ACL heals. Would that be fair to say? What's your current stance on that topic?
Well, the first thing I'd say is we don't know, and that it's another knowledge gap that we're trying to address. What I think, this is level 4 expert opinion, evidence-based medicine. From my experience, is that I think if we got 1,000 people of a certain age, doesn't matter whether they're male or female, there'll be early involuters and people that stay open for healing longer. So I think, in my experience, some people might involute at day 18, and then other people stay open for healing longer than that, to do with their genetics, their health, it's their tear type, whether there's a breach of the synovial envelope. So once you breach the synovial envelope, all those beautiful cytokines, inflammatory mediators pour into the knee and get diluted. That's not good. So if you've got an underspaced ACL, you probably stay open for healing longer. So there's a lot of factors. The latest person who's healed is day 33, and it was a 13-year-old girl in New Zealand. And her mum and dad were both physicians. Mum was a renal physician, dad was a respiratory physician. And I said, look, I'm really worried. It's day 33. And they said, well, what have we got to lose? She's tiny, she's 13, she's a ballerina. And it worked. But she was a 13-year-old child, and maybe children may stay open longer for healing. But there's a certain time where the healing potential falls off the cliff, and the epiligamentous tissues cap over and close, and you could bend the knee till the cows come home and you won't get any healing, or you won't facilitate the healing. Knowing that time, we don't know, but I get worried if they're coming in more than 21 days. I worry that, and I often do another MRI, because the MRI might be 14 days ago, and I want to know what I'm looking at is present, what's happening inside that knee right now. So I'll get another MRI and have a look, and more often than not, the epiligament is capped over and smooth, and we think that's a radiological sign of involution. And I don't offer the CBP to that patient because it's a challenging treatment for the patient and their family. And I say, you do rehab alone and try that, or this is the name of an expert surgeon.
And that ability to see
the time pressure.
Sorry, Thomas. Yeah, that ability to see if the stump of the ligament has sealed over and involuted. Is that something that most radiologists can do, or is that a really specialist skill that there's very few people who can diagnose whether that's occurred or not?
Yeah, because for many decades, since MRI came in the 90s, really, so we've got 30 or 40, 30 years of experience, 30 to 40 years. Remember that, for the last 20 years, we've been talking about spontaneous healing, and it was thought to be an enigma. And we believe the spontaneous healing ACL is the less injured ACL, or the moderately injured ACL in the patient who sits down all day and they get a degree of anatomical restoration. But for most of our careers, we've thought it's a ruptured ACL, or it's a partially torn ACL, or it's a normal ACL, and it was very binary. So not a lot of radiologists have been trained into, well, that ACL is still alive and it's a fresh ACL, or that ACL is acute on chronic because there's signs that just don't fit that happened 5 days ago. Or that ACL's day 28, it's involuted and capped over. So they're not trained, and with the we're trying to address that knowledge gap. We're collaborating with the University of Sydney in optimizing the software and hardware specifications of the MRI, and we're also trying to get 3D MRI, so you like a CT, where you put the CT up and look at the bony fracture and work out whether that fracture needs surgeon, or you can treat it with a closed reduction. We're trying to do that for the ACL, and then add in deep learning, artificial intelligence into that equation, and that starts getting really exciting. So the answer is no, but maybe in the future the MRI could tell you whether there's blood flow in the stump. Is it still alive, or is it capped over? Just like you would for dynamic ultrasound to look for blood flow. So it's an interesting space, but that's why it's so important. If you can get them in your clinic and you're having the conversation on day 5, it's wonderful, because the patient's got all the options open to them. And if it's day 35, you probably lost the option of facilitating the healing.
And I know we're starting to run out of time, but just finally, I'd like to speak a little bit about selecting a bracing protocol, and if you're getting any more clearance around what tear type or patient types are amenable to, say, a 40 to 90 versus being locked at 90, and the time frame of the bracing protocol as well. I know there's the 6 and the 8 and the 12-week protocol that you've been kind of prescribing in various different levels to different patients. Are you getting any more clarity around an optimal bracing protocol?
Yeah, sure. So if we go back in time to 2014, when my father Merv and I were talking to Emma about this idea of bending the knee, Merv and I spoke about what angle should we go to optimize the healing, but not close down the popliteal fossa and the neurovascular structures. And we chose 90. And then we said, well, how long will we hold them at 90? And then after talking with my father and I, for any sort of soft tissue or bony injury, you want to achieve an adequate reduction and immobilization that will enable cross-bridging of collagen in this case. So we chose 4 weeks at 90, and that's the history of the idea. And then every week thereafter, you incrementally bring the knee into extension and you remodel the ACL. You protect the ACL, but get your range of motion back with an excellent physio. In the first 100, we had significant arthrofibrosis in 6 patients. And we looked back, and they often had a grade 2 MCL. They're not a grade 3, but a grade 2. And then we thought any grade 2 or 3 MCL, we dropped it to 2 weeks at 90, and then did this accelerated protocol called the 6-week protocol, whenever there was an MCL or a significant post-lateral corner injury. So that lesson came around patient 100. And then patient 330 was a Irish physio called Emir. It's a female Irish name, and Emir, I can never pronounce it properly, but she said, Tom, this 4 weeks at 90 is bollocks. I'm gonna do 3 weeks at 90. And I said, Amir, you can do whatever you like. You're a physio, you're the patient. And she pioneered the 8-week protocol, which is 3 weeks at 90. So it was a patient, and often the patient, you learn a lot. She did the 3 weeks at 90 and it worked. And now patients who are early presenters in the first 7 to 9 days, we often prescribe the 8-week protocol, 3 weeks at 90 rather than 4. So that, and then there was the evolution of the hybrid, which is for the patient who finds locking at 90 very difficult because they've got young children. They might be a single mum, single dad. They're a tradesperson. They're a physio, and they just say, look, I can't do 90 all the time. And that was a physio in Texas called Sandra Gomez, who was patient 293. And she said, well, can I do 90, 20 hours a day? And can I do 4 hours where I go to work and I'll have it 40 to 90? And I said, Sandra, you can do what you want. You're a physio. I'll support whatever decision you want to do. So she reached down and locked the brace most of the time and lock it for sleeping, but have the ability to unlock it for when she needed to work. And she healed. So we've got this flexibility of prescription. It was a proof of concept, the going to 90 and holding it at 90, but knowing what we know now with the spectrum of injury and gap distances, taller people get a bigger reduction because they've got a longer ACL. So we've worked out now a ratio of gap distance to ACL length. And then you may not need to go to 90 to get the reduction. So in the future, we may have bespoke bracing protocols. So if someone's got a 3 millimeter gap, they don't need to go to 90 to close that gap. They go to 45. We haven't dared to do these bespoke bracing angle protocols yet because we're still trying to prove the CBP. And people who are critics of the CBP say, Tom, they would have healed anyway. You're putting all these people through an unnecessary protocol. So we would argue the contrary to that. We believe that a lot of them, the more moderately injured to the bigger gaps, they would not have healed. They would be ACL deficient. Another interesting finding is over the course of the research in this 7 years, is there's different clusters of tear types in different sports. So all those sports I talked about, let's talk about skiing. It's a focus of this podcast, and the one before is that's the group of ACL injured patients we can help the most with CVP because they're often low velocity skiing injuries. Often the advanced skiers don't often get injured. Like you said, there's 15 patients that come in and that are a low velocity. There might be a beginner adult. Unfortunately, if they're a beginner child, they have the highest percentage of undisplaced ACLs. So that means the injuries that occurred in the synovial envelope. Let's go back to that sausage skin analogy. The sausage skin or the membrane is not breached, and there's a variable amount of disruption of the ligamentous tissue, back to our analogy, the sausage. And there's a lot of skiing ACLs that are non-displaced. In our experience, it's 60%. So now if you then go to a cluster of, let's look at all the soccer ACLs or the netball ACLs or the AFL, rugby union, touch football, OzTag, it's flipped on its head. The majority of them are displaced. They're more injured ACLs. So different sports have different clusters of tear types, and the skiers are the ones we can help the most. Also, jiu-jitsu, mixed martial arts, they tend to get a lot of undisplaced ACLs because they happen with twisting moments. Often the athletes are quite stiff individuals, so we think their Baton score might have a degree of how much excursion the femur on the tibia makes. So you tend to find a lot of healable ACLs in the mixed martial arts group. And yeah, it's slim pickings in the other categories. Touch football, OzTag, netball, basketball. It might be 15 to 20% of them are a good candidate because they get injured with high velocity, high force, equals more disrupted ACL, larger gap distance, breach of the synovial membrane, displaced ACL. So the type of healing you'll get is non-anatomic, and that young 22-year-old wants to go back to soccer. So now we have this knowledge, we can say, well, this is what CBP will give you. It's got probably a much higher re-rupture rate than going back to seeing an elite surgeon. That's what we believe, but we need to. There's an RCT going on in Australia at the moment, trying to determine whether there's validity in what I just said, and that's the Embrace RCT, comparing reconstructive surgery with the CBP. There's a RCT about to happen in New Zealand called the Encore RCT, comparing CBP plus rehab to rehab alone. And then there's an RCT starting in the NHS in the UK called the Braver trial, which is comparing cross-bracing with rehab alone. So the take-home message is we're still investigating the CBP. There's different clusters, different tear types in different sports. You need to see someone who knows about it. And the team of 4 to look after you if you are a patient out there. And hopefully you heard Ryan and Bevan speak about mitigating the risk of injury and you heard on your skiing holiday. But if you do, you need an expert physio, you need an expert radiologist and MRI machine to classify your injury. You need a doctor that's involved and knows about CBP, and you need an expert surgeon. And we're all in the team trying to help that ACL injured patient. We're all working together to work out what's the best first position of management for that particular patient.
Terrific. That's probably a good time to wrap it up, because I'm sure the 3 of us could probably talk for several more hours on this super interesting topic. But thanks everybody for tuning in to another episode of the Knee Gurus podcast. I hope you all enjoyed this conversation as much as I did. And a huge thank you to Dr. Tom Cross and Ryan Kerr for sharing their experiences, insights, and passion around ACL and skiing and ACL management and healing. If you enjoyed this episode, please share it with a colleague, friend, or anyone dealing with ACL injuries. And don't forget to subscribe so you don't miss an episode of the Knee Gurus. Until next time, keep learning, keep moving, and take care of your knees. Thanks very much for joining, fellas, and we'll speak again another time.
Thanks, Bevan.
Thanks a lot, Bevan. Appreciate it.
Bye for now.
Thanks for tuning in to the Knee Gurus, brought to you by Asia Physio. To learn more or explore online consultations, visit telephysio.com or asiaphysio.com. If you found today's discussion helpful, share it with someone who's exploring their knee recovery injury options too. Thank you, and bye for now.